Hello, everyone. We are coming back and we are slowly starting with the last three sessions of Data Science Conference Europe. What I wanted to tell you that we are going to have three distinguished and excellent keynotes. And first of them is going to be the good friend of our conference, Pradeep Goel. Basically, Pradeep Goel is CTO of Solve.Care, and he has extensive expertise in blockchain, finance, technology, and healthcare. He has been in the CEO, COO, CEO, and CTO roles at various insurance, technology, and healthcare companies over the last 30 and more years. Pradeep was deeply involved in designing and building solutions for public programs such as Medicaid, eligibility and enrollment, Children Health Insurance Program Administration, Medicare claims, SNAP, TANF administration and payments, Child Welfare Program Administration, and many more. Pradeep worked with the healthcare initiatives of both the Bush and Obama administration to design and build several public program solutions under the Health Savings Act and Affordable Care Act. Prior to founding Solve.Care, Pradeep built four healthcare IT companies and has been at the top of Deloitte Technology Fast 500, INSEE 5,000 fastest growing companies list multiple times. Pradeep was included in the 100 most promising entrepreneurs globally, complied by Goldman Sachs. I would like to invite Pradeep to join us at the stage, and he can start with his keynote talk. Hello, Pradeep. Nice to see you again.
Hello, Alex. Thank you for having me, and it's very nice to be here today. And thank you for the very kind introduction. So we will get started in the interest of time. I want to talk to you all today about healthcare, the use of data in healthcare, and how we are imagining a future in healthcare where data is, instead of being aggregated to the benefit of institutions, is used primarily for the benefit of the patient and the provider. There's a lot to cover. There's a lot of concepts that I want to share with you today. So we'll get through a fairly lengthy information deck here. And I hope that we'll have some time for questions and answers. So let's begin. I've been in healthcare for 30 plus years, and I've worked with many government institutions in US and abroad, and with many commercial and clinical organizations. And no matter where you go, be it the USA or the UAE, you always hear the same objectives. We want better health for our patients. We want to deliver better care through the physician population, and we want to have better value for the money spent. You would think that with such a simple, clear objectives in every healthcare system, health policy, or health program, we should be closer to this goal. And every health policy looks like this when you distill it down to where we are going to have a consumer-centric system where insurance companies, government agencies, employers of the consumer, the physician taking care of the patient, the hospital where one needs to be admitted, and third-party providers like labs and pharmacies all work together for the benefit of the consumer. And there is always this view that if we can somehow build a mechanism where all these parties around the patient somehow share data with each other, somehow transact with each other in a more efficient manner, we can improve access to care, we can reduce the recovery period, and we can also protect patient rights and patient identity, and we can create a system that's more trusted and reliable. So this is the universal goal. Now, if you live in UK or in Canada, where you have the benefit of centralized government sponsored and managed healthcare, you might see this picture in your government policy. If you were like me, working in the US, where there is a lot of different models of healthcare, commercial, government, self-pay, concierge care, you would see this model presented in the context of the program. But the reality of this, of healthcare, is nothing like the picture. The reality of healthcare looks a little bit more like this, where data is managed by these entities on behalf of the patient. So as an insurance company, I had a claim system. My providers, hospitals, and physicians had their electronic medical records or EMRs. The employers had their own benefit databases. The government agencies have citizen databases, and all of these entities are carrying a piece of my information, my identity, and my health information. And then the theory of the US healthcare system, and really the worldwide, is that if all these parties on the right talk to each other for my benefit on the left, then healthcare will work better. Except it doesn't, because you are disintermediating me, the data subject, from this process of collection, sharing, use, and aggregation and analysis of this data. And oftentimes these parties on the right cannot even identify me as who I am. In the insurance company system, I might be Goel Pradeep. In the government system, I might be Pradeep Goel. And believe it or not, often that leads to one system not finding me as the same patient as the other. So this notion that we have to connect everyone with everyone before anyone can benefit from it is the fundamental data management flaw of healthcare, where I am a outsider peeking into these various silos. And if I'm lucky enough to have access, I might get a piece of the data that belongs to me or refers to me, but none of these parties ultimately have the complete picture. Because here is the irony of it. All these systems on the right-hand side cannot predict whether I have taken my aspirin this morning or not. They cannot predict whether I have a backache or whether my temperature has gone up. All they have is retrospective data. All they have is historical pieces of information. Here is another fact to consider. In healthcare, clinical data has a very short shelf life. A doctor may look at your data in the last 30 days with interest, with 60 days old data, with some level of historical interest. And once the data is older than 90 days, it's largely a defense mechanism, but it has no relevance to my prognosis or diagnosis for the most part. It may give me an indication as a physician as to where to look, but I'm going to collect new data. Simple way to look at it is this way. How many times have you gone to the doctor and you've handed him an X-ray or an MRI or a blood result that's over 120 days old, and the doctor has said, well, this is good enough. This blood test is just fine 120 days ago, so I don't need to do a blood test for you today. The doctor would end up in prison for the most part for doing malpractice insurance or malpractice because they did not even bother to assess your current risks. So the healthcare data shelf life is very short, which means that unless it is shared in a timely basis, it largely becomes useless background information. If you are interested in taking care of the patient. Now, if you're interested in mining the data for pharmaceutical research or for the purpose of cost management, you can use that data meaningfully. But when you talk about data for the use of the patient's value of that data is receding very quickly. It's like any radioactive material, it degrades, its half-life is very, very short. It degrades very quickly. Then you have laws like HIPAA in the US and GDPR in Europe, which try to address the issue of who has my information and who controls it and what they use it for, but they don't really address the real issue that I don't even have my data in my control. So those are the challenges, and these are the reasons why healthcare is ultimately such a complex equation, because it's not like a standard commerce transaction where you can have party A buys service from party B and party A pays party B and there is a transaction cost and you're done. Healthcare delivery is multi-party, interoperability is multi-party, regulation, privacy, and local customs require third parties involvement. And there is the lack of trust between these parties. So we have estimated that if one could use a decentralized tokenized model of healthcare data management, then we can save $1 trillion or more a year in administrative and financial costs and missed care opportunities or more. And that's just a US number. So it all boils down to how we manage data, and actually who manages data is the fundamental problem in healthcare today. So let's take a look. Now, this illustrates the problem. I've been in healthcare for a long time, but this is just the last 6 years. We keep talking about health costs are rising. This gives you an indication of how quickly they're rising. While we were facing with a relatively stagnant global economy, we have in the last 6 years seen healthcare costs rise far beyond the CPI, the Consumer Price Index. In the US, the curve is always like this. Each year we see medical cost inflation. It's not that different in the BRIC. It's not different in the euro, although just the trend lines are slightly less steep, but the costs are always rising. And this is a symptom of the problem. And the underlying problem is the ineffective and inefficient and largely unavailability of data in healthcare. So now, what is a better approach? An ideal approach here is that a patient, you and I, a consumer or a patient, depending on whether we are a parent of a patient or we are the patient ourselves, or the patient has the ability to manage their information and publish their information to the entity who needs that information for the duration and purpose for which they need the information. Instead of relying upon a picture like this, which will never come to fruition in practical sense because of the interests of these parties are orthogonal to mine, we need to change the picture where I publish the data to the entity on the right. Whether I need to participate in a transportation or a wellness or a diabetes care or mental health, as an example, or a teleconsultation service, I need to be able to publish the necessary information to that service, not hope that all these services talk to each other. And if we can achieve that, we can flatten the bell curve and flatten the curve of cost and actually deliver patient-centric care. So it all boils down to, how do you manage healthcare data? So let's look into this. Now, healthcare data, when you start dividing it into data categories, it boils down to the following key data categories and data operations. There is always the question of identity of the patient. It's always a question of how much you need to know about the patient's identity to provide them a service. So for example, if you're a physician, you need to know my clinical identity. You need to know what medical history I have, what disease or vaccinations or prior allergies, reactions that are known about me. So you mostly need my clinical identity. If you are an administrative entity, like an insurance company or a government agency or even a hospital admission desk, you need my consent to treat. If you're talking about a referral or from a primary care to a specialty care, we need to have the ability to manage care events for the patient. If you're talking about the ability to coordinate complex care, such as diabetes or cancer, we need to manage long-running transactions, which carry the data with them. If you're talking about who pays whom, we have to have both direct and third-party payments. And among all of this, we have to have auditable data sharing so we know who, what, when saw the information to comply with various health laws. And this all needs to happen somehow in a way that a patient can control all of the above. And that is what we have been working on for the last 4+ years, is building a solution, a decentralized, distributed data management for healthcare, where these functions and these capabilities are being extracted from the legacy centralized system model and put on a fabric where the patient or the participant, as we call them, has the ability to control, manage each of these 6 dimensions of their data. The end result is that I, as a person in the middle, have the ability to transact with other parties through a well-defined ledger or a fabric, where I can send either data or events or transaction states or payments, and I can do so in a manner that is completely transmittable and is essentially a publish-subscribe mechanism, where any party who wants to transact with me can subscribe to my data feed or to my data node in this case. And my interaction with them has to be standardized from my perspective, but can retranslate to the recipient's desired format. So this is a relationship-driven model where pharmacy A can forge a relationship with person B by subscribing to the person B's node. And once they have done so, they handshake and they can safely transact whatever they need to transact with each other without any risk that the doctor-patient relationship would be impacted, which is a different relationship, versus an insurance patient relationship, versus a citizen government relationship. So all of these relationships that exist in healthcare simultaneously, and in fact, they exist in life simultaneously, can be managed through this decentralized health networks that are now possible on a platform like ours. Now, what does that mean? What that means is that when person A on the left wants to talk to Dr. B on the right, there is a well-defined model of handshake called the protocol, which allows person A on the left to do a handshake or a care relationship with the person B, and that relationship is established between their respective nodes. And when that relationship is established through sending of a card or an acknowledgement and receipt of a return card, that event triggers a node-to-node relationship. Once that relationship is established, there is a private tunnel of communication between these two nodes, which protects the information but writes the event that underlies the exchange of information on the ledger. So now you have a separation of data. You have identity on the left side in the left wallet, identity on the right side in the right wallet, a handshake that only requires the address of the two nodes, and data that is exchanged between these two nodes directly, and all the exchange information starting with the handshake written as event in an immutable ledger. And now you have created a data hierarchy. You have the ability to do systematic release of identity only as much as needed to perform the transaction, not more. You have the ability to transact freely between nodes in a secure private manner, and you have the ability to have full auditability of the transaction between the parties in the event ledger. So now you can actually enforce a different way of doing identity, a different way of doing consent, giving and revoking. You have complete transaction state management, you have complete peer-to-peer payment capability, and you have the absolute ability to see who accessed your data, and more importantly, if you want, you can revoke access to data that you have granted. In other words, I can unsend a card after I have shared it because you no longer have a purpose to have that information from me. This is a very different approach than all the current systems where we have a centralized database and everybody pushes their data into that system through a web app or through a mobile app and hopes to receive some of the data back through that same portal. And the data residency is the same thing as data ownership. Whoever's database I am pushing data into owns my data, which means that the moment I give you data, I lose control over it and I have no visibility into how you use that information. In this model that I am showing you, I have absolute visibility through the event ledger on who saw my data and who I want to unsee this data. Now, what does that mean? Let's look at the practical example. So now I'm a patient and I want to make an appointment with a doctor. I have the ability to send a request appointment card from my patient node through my wallet to the doctor's node. Now, the doctor node on the right-hand side could be a known doctor who I already have a pre-existing relationship with, or it could be a whole series of unknown doctors with whom I wish to transact with, but they have not yet accepted a relationship request from me. So in effect, I could broadcast a request for an oncologist, and I don't know which oncologist node will accept it, but I know that I want every oncologist in 50-mile radius from my node to be able to respond to my request. And the oncologist that has availability, that's accepting new appointments, that accepts my insurance card, that speaks my preferred language, would be the node that I would ultimately forge a transaction relationship with. And when that happens, that oncologist node can present their availability to my node, and I can accept, or the time frame that availability time that they have, and they can accept my identity or my eligibility as the confirmation of appointment. In this scenario, the data about me as a patient and the data about the doctor as a provider is only exchanged between us. There is no centralized database where I have to go fetch a provider registry or provider availability from. And the patient and the doctor only share the information that is needed for them to transact. And maybe at this point in time, my clinical identity is not needed, only my benefit identity is needed. But when I actually consult with the doctor, I can choose to share my clinical identity or my medical history, if you will. So you see the idea of and the power of a tokenized system is that you can not only move data peer to peer, not only can you track it, you can link to that event an automatic economic value, which means that when the appointment accept event comes into my wallet, I immediately and automatically am obliged to transfer a certain amount of assets to the doctor's node, or when the appointment is completed, that event triggers an automatic payment. So in this scenario, we eliminate an enormous amount of friction, but more importantly, loss of control over data by the patient or the doctor. When you take this further, it gets very interesting when you start looking at various different networks that I can participate with at the same time. So as a patient, I could join a diabetes care network, an insurance network, an employer-sponsored network, because those are the networks that or network services that I am interested in. And for each of those, I can have a whole host of underlying service providers who are getting paid, but my objective in joining that network is to transact with those who are offering services in the network. And I share only as much identity as I need to, and only as much as data as I need to with each of the providers for each of the services that I'm consuming. So that no one needs to know everything about me to do anything for me. They only need to know as much as they need to know to deliver the exact service that I wish to acquire and the data that is relevant to that service. No more, no less. So now, why is this important? Because in healthcare, the administration activity is actually almost as much as the clinical activity. The amount of upfront activity that happens prior to a patient-doctor interaction and after the patient-doctor interaction is complex. You have multiple parties that get involved in the process of verifying my identity and my eligibility and giving me an appointment and sharing and collecting my medical records. There is multiple parties who have orthogonal interests. So the insurance company wants to manage costs, the doctor wants to deliver care in an unfettered manner, the health regulator wants to make sure the care quality and the cost are reasonable. All of this creates this fundamental friction between parties that are supposed to collaborate. And of course, then you have local laws and government laws and international laws that need to be complied with. So in many ways, the cost of administering healthcare is as big as clinical care costs, and it's growing rapidly because more laws are getting passed, more awareness around patient rights and provider risk is there. So every time you have a patient-doctor interaction, a patient-specialist interaction, a payer-doctor interaction, a payer-patient interaction, an employer-payer interaction, there are completely different set of laws. So, and those laws are so different and so fundamentally orthogonal to each other that trying to implement any system where you can implement patient doctor rights and patient specialist rights and payer doctor rights, it's mind-boggling, it's impossible. So what you have to do is to decouple all these complex rules into relationship context, where we only worry about implementing patient privacy and doctor obligations and vice versa inside the patient-doctor interaction, and we do not need to worry about the employer's obligations in the context of OSHA and other things to the payer. So you see, the idea of healthcare from a centralized perspective has become so difficult and so expensive that a decentralized model, which is relationship-based, is really the only way forward that I can come up with after having spent 30 years in this industry. Now, when you start using a decentralized model of data, it becomes really interesting because what we can see here is that we can create an ABC relationship, which is very difficult to do in a centralized system, and where A can trigger an event that causes B to do something. And just because B took an action on the request for A, C can get automatically notified. So in a simple example, I make a request as a patient, role A, to an ophthalmologist or optometrist for an appointment. And that appointment is confirmed by the ophthalmologist and perhaps an upfront payment taken. And the payer, entity C, can be notified that Pradeep plans to go see an ophthalmologist next week, and he's made a prepayment of $25, which allows a payer to essentially process my claim and pay the ophthalmologist post-visit. So AB event triggering a BC notification or an AC communication streamlines vast majority of the healthcare complexity. If you can think of healthcare as a triangle at its very simplest sense, patient, doctor, payer, if A talks to B and B responds to A with either affirmative or negative response, and C can be automatically and safely notified of the necessary and only relevant data, then we can streamline most of the care coordination, payments, and compliance. So we have implemented a series of solutions where we have built solutions as wide-ranging as transportation provider, who is providing transportation for every known appointment between doctor and patient. We have built solutions for diabetes care coordination, for provider payments from third parties based on quality of service, and so on and so forth. These are very complex networks that we built ultimately in the same fabric of data management that I described earlier. Now I'll get to for some of the more interesting opportunities. One of the biggest problems in healthcare is how do I share information with the other party when I don't know what the other party's systems are? So I'm a patient, I want to send my data to the doctor, to the specialist, or to the lab, or to the pharmacy, and I have no idea what their systems are. I have no idea what format they can accept the data, and I don't even know where to send it. So what we have designed is a concept of a tag-based publish subscribe model, where when a party wishes to get data about me or for me or from me, they can request data in the form of a care tag. In other words, they can refer to my care tag, which is my unique wallet ID, and they can seek information from me. They don't need to know my identity. They only need to know my tag ID for them to request information about me. And now I have a choice of responding to that tag ID and giving them a certain care card attached to it or not. And the same thing works the other way. If I want to allow my physician to share my data with my specialty care provider, I can simply give the specialty care provider a key to my tag, which allows them to essentially get the record directly from the physician's wallet, but now they have the key to actually untangle the encryption and read my tag. So the idea of the care tag is essentially fundamentally the ability for me to tag my data, send it off into another wallet, and control whether that wallet or another wallet can read that tag, and therefore I know how far does the data that I have pushed out propagates. And if it does go further and further out, I am secure in the knowledge that the recipient does not have the tag key to unpack this data. So what that brings us back to is the picture where a person-centric healthcare delivery model, where person is truly in charge, where the person is truly in control of their data, where they are publishing and consuming information about themselves in a manner that is appropriate and relevant to their care delivery, and where third parties can subscribe to, request, and receive data for the purpose of delivering care services or getting paid for it. That entire model shifts to a true person-centric data management. And identity, consent, transaction, payment, data sharing, all those are done in the control of the patient or the person who owns the information, which is me or you. And having built that framework, it becomes quite easy now to really build far-reaching global solutions where the patient's location and the doctor's location and the pharmacy's location, the specialist location are no longer geographically constrained. Because I have the ability to send information and control my information, not just by who has access to an EMR database and who has registered provider in the provider registry. I can interact with a physician in Canada, even if I'm in the US or in South Africa for that matter, as long as I accept the tags of the physician, agree with the fact that this physician is someone I want to interact with, establish my relationship with them, and handle all the rest of the consult with them. So one of the great advantages of using a patient-centric or a consumer-centric data control mechanism is that now the consumer has much greater choice, whether it's in the context of care or devices or services or collaborating with the family members. I could be living in the US and my parents could be living in India. For me, it's a simple matter of creating a care circle, which allows me to share relevant care cards with them automatically or manually, knowing full well that the data residency and control lies with me. Now, having done all that, there are many kinds of solutions that can be and are being implemented on the platform: disease management, care coordination, physician efficiency, care opportunities, claims processing, prescription purchase online, vaccination registry. There's all kinds of really interesting use cases or solutions that lend themselves to a new way of managing data, from a transparency, from an auditability, from a security, and from a immutability baked into the data fabric. Now, those of you who are, and many of you who are listening, are part of the data management and data scientists. Imagine each data set to have its own identity. So you have not just a data set, which is in the form of a data structure, you also have the ability to have a data view, which is specific to the role of the viewer. The same piece of information that is shared between wallets is viewed entirely differently by each wallet, depending upon the role of the wallet. So a physician might want to look at my trend line, but the same data set sent over to a patient might be viewed in the context of aberrations and abnormalities, versus the same data sent to a lab might be seen as a opportunity to reconcile the lab results with my past lab results. So the data set is now married to an actual context of the data, and the context is married to the viewing capability of the data. So same data set can be visualized differently inside different wallets, but it's the same event, it's the same block of data, but the visualization is completely different based on the role. So that again leads us to a much more effective way to deliver complex solutions to consumers in a very understandable manner. Because what we are looking for is a grandmother to be able to manage her healthcare without having to get a PhD in health policy or health science. Now, I want to give you a quick view of how this all looks from a consumer perspective. Now, this is a practical example of how it works in the real sense. But what is more important here is that underlying every one of those interactions is a data exchange event between party A and party B, which is based on a relationship model that has been established, which determines the event types, which determines the consents, which creates an immutable care ledger, which can be studied later on without carrying the identity of the sender or the receiver, but giving us enough information to see if the care is happening in the way we want it to happen. And this model was used to build the diabetes care network, which is one of the most advanced diabetes care solutions out there. built in partnership with Boehringer Ingelheim. And it's a very interesting and complex data management problem, ultimately simplified to an ABC relationship between a patient, a care provider, and a physician, a care provider and a care coordinator. Now, in summary, what we are trying to do as an organization is to reimagine health data management, where patient privacy, their sovereignty in terms of data ownership, and the interoperability of the data across different health services and networks using blockchain as a fabric is the mission. And we have taken that vision and that mission and broken it into a multi-tier architecture on the platform, which allows us to build very complex, very powerful healthcare ecosystem called care networks very, very quickly. As an anecdote, when I was previous to Solve.Care working in large insurance environment, modifying a member benefit plan or introducing a new member benefit, even something as simple as authorizing a new drug that the FDA has approved for prescription, and the agreement that will pay for this drug now could run into millions of dollars. To make that change in the systems, there is a scenario I recall well where one of my vice presidents came to me and said, "Let me show you our member enrollment process." And she had a stack of paper that she ended up pasting on the wall. It was about 60-foot long process that if you walk along the walls, tracing the steps, it was about 60-foot long printout. Now imagine having to modify any step in a 60-foot long process, using IT resources and requirements and design. No wonder each time we had to modify a benefit plan, the budget was in the millions of dollars. This is why healthcare costs so much, because we have built historically over the last 50 years incredibly linear, centralized, inflexible data management systems where piece of the data is in my control, the rest of the data is not. I'm relying upon interoperability to bring that data together, which never happens. And no wonder the healthcare costs keep stepping up. And this decentralized, distributed, and autonomous data model, we believe, can address the heart of the issues in healthcare. We are spread in many countries. We welcome innovators and thinkers and people who believe the status quo in healthcare needs to change. Join us. We have many projects, many activities, and lots of capability to reimagine and rethink healthcare. You can find us on Telegram. You can find us on the web, of course. You can find us on LinkedIn. You can find us on many different forums. Solve.Care is the company, and I would welcome hearing from any and all of you. With that, I'm going to turn it over to you, Alex, and see if there are any questions.
Hello, Rajiv. Sorry, Pradeep. We are waiting for Rajiv after you, CTO of Grid Dynamics, to join us as well. We have some interesting questions. I would like to come with first. Let's go in with Q1. How much diagnostic outcomes are worse because of the data mismatch? Is there any comprehensive research on this topic, perhaps?
There are many independent studies, but they're not a broad study. They always tend to be in the context, but not always. Most of the studies are in the context of certain diseases, particularly chronic diseases. So when you look at diabetes care, both juvenile diabetes, type A, type B, when you look at pediatric oncology, there are studies around, plenty of studies around what kind of care we should have delivered versus we did or did not deliver. So the studies tend to be in the context of a disease condition and against a optimal care journey, if you will, an optimal care protocol. And most of these studies will tell us that if the data was timely available, we could have avoided duplication of tests, or we could have accelerated the test before we made 3 tests to figure out what the real test is, that we could have coordinated care between payer and primary care and specialty care provider easier, and so on and so forth. So yes, there are plenty of studies. From an insurance company perspective, well, I'm no longer there, but insurance companies do a lot of studies around how to improve cost, how to improve outcomes while reducing cost. And all of that is based on the idea that if timely data sharing took place, inevitably, healthcare would have been better in terms of reduced suffering and reduced cost. So I can point you to a number of studies that were done by CMS, Center of Medicare and Medicaid Services, in the early 2000s, which are still very relevant around interoperability and the value of interoperability in healthcare. But the only thing I'll caution you is that those all ultimately arrive at the conclusion that if everybody talks to everybody, then things will work great. And that has been the false premise of the decade, that nobody really talks to anybody. So therefore, none of those goals were ever realized.
Okay, we have. I would like to have. We have two more questions. I will leave the second question with Japan for the end. The third question is: can we say that tokenization is an enabler of personalization in this case? Is decentralization really needed for this?
So, but tokenization is certainly an enabler of transaction capability. And since you want to be able to transact with both known and unknown parties, tokenization makes it easier to transact with unknown parties. Because people always say to me, look, if I know my doc and I know doctor's home address or office address, I can always mail him a check. You're right. To the point where party A and party B are known to each other, there are many payment mechanisms. But when you get into a scenario where party A is looking from a role B, when party A is searching not for an individual B, but a role B, at that point in time, payment becomes quite a bit more complex because you are going to have a very limited choice if you only seek services from those with whom you have an existing financial relationship. And that's one of the big reasons why healthcare networks are narrow, where you're told as a patient, you can only go see these doctors, but not those doctors. Why? Because you don't have a payment relationship with them. So a token allows you to transact with an unknown party as long as they have credentials, right? So that's one thing. Now, is decentralization of data really needed? Absolutely. Because from a compliance perspective, in most countries, there are clear laws around who can see what information, and more importantly, where the data residency must be. So in the sense that you want to transact between parties who are not related to each other initially, and you want to create on-the-fly care relationships, you have to have the ability to transact in data and to untransact in data at some point in time. And you want to have people to be able to subscribe to your data, and you have the right to publish or not publish it. So can we achieve a compliance world where patient rights are protected and physician has access to timely data and the patient controls data, even if it's not in their custody, through a centralized model? Theoretically, of course, we could, but it is going to be incredibly difficult and practically impossible. Technologically, one can argue it's doable. Practically, it doesn't get adopted. And I built many systems based on the centralized database technology, of course, 3 decades of it, where the other party, whether it's the hospital system or the doctors, who refuse to rely upon my data set because I controlled it. So decentralization is needed if you're going to achieve equanimity of trust between parties who are publishing data and parties who are consuming that. Because from a doctor's point of view, prescribing a medication based on false or incomplete information is a recipe for disaster, and nobody's going to care that the doctor had the wrong information if the patient dies. So there is a need for decentralization of data to create trust and control.
Okay, and last question, and maybe if you can, if I can ask you to maybe just give us a short overview. There was like one slide with the cost of the healthcare, if I remember correctly, and there was a question: why Japan is not having an inflation? Because every other country and every other group has, but Japan doesn't have the inflation in healthcare services cost.
So there are a number of factors, and I'm not an expert, but I have only a somewhat of a high-level view of that. So in terms of Japan, there is the model certainly is a centralized healthcare where the government controls the rates. So the reimbursement rates for physicians are set centrally. So the quality of care is not the driver of your payment model. It is set centrally. The second scenario is the demographics of Japan. They are unique. And if you study them, you'll realize that it's not that healthcare costs are not going down, or they are not going up. It's the consumption of healthcare is changing, which is a function of their overall population demographics. But in general, it would be incorrect to say that the Japan is not experiencing overall medical inflation. It's the distribution within that is very unique. They are a very unique set of demographics at work. But I would say that if you look at the more recent data from Japan, even they are starting to see inflation of the nature that's going to show up in these numbers. But I would say that Japan is a very specific case that needs to be studied for its combination of demographic as well as government control over reimbursement, which is unusual because in most parts of the world, reimbursement rates are not set by government for the most part. Now, US is going there slowly and surely with Medicare and Medicaid reimbursement, but it also has a significant impact on the physician efficacy. So it's a complex question, but there are definitely pockets of inflation within the Japanese data as well.
Okay, Pradeep, once again, I would like to thank you for joining us for this keynote talk. I think that all of us learned a lot. We have talked for a lot of good topics, and for sure we're going to continue talking, and we will take our freedom to share the contact. So if anybody is interested in the Solve.Care story, you can also contact Pradeep or Solve.Care members all around the globe. So Pradeep, thank you once again for joining us.
Thank you for having me, and thank you everyone. Have a great day. Take care.